we're delighted to have such a great group here today for our session, Growing a Global Health Workforce. We know there are a number of others that are at the Jerome Hotel waiting for shuttles, so more will come and join us in a minute. But we really have a fantastic lineup of people today, so this is a critical issue. I don't know how many people are aware of the fact that by most estimates, there's a health worker shortage of 14 million people by 2030, which is huge. That's a really big problem. But luckily for us, we have some folks in the room here who have huge hearts and huge minds who are going to share with you some of the ways that they've been breaking through this huge challenge. So we're going to do this fun deep dive in 3 chunks. The first chunk is going to be 3 magnificent TED Talks from people who will rock the house. They'll be 10 minutes each, and then we'll have a little tiny bit of question with each of them afterwards. And then I'll be really honored to invite onto the stage 2 incredible activists and heroes, Ajen Poo and Dr. Agnes Binagwaho of Rwanda. With me, we'll be sitting here together having a really interesting conversation about the health workforce shortage, both in the US and globally, and some powerful solutions for that. And then we're going to invite everyone back up on the stage, and we're going to open it up to you. And we're going to have a really fascinating conversation together about what's possible. So that's what we're going to do today. So without further ado, I'd love to welcome our first TED speaker, who is someone who is a hero of mine and of many people here, and has become a dear friend, Raj Panjabi. Raj Panjabi is the Associate Physician in the Division of Global Health Equity at Brigham and Women's Hospital and Harvard Medical School. He co-founded Last Mile Health, which, I've made a mistake. I'm so sorry, because we've changed the orders. Well, you want to go with Raj first? No, okay. Sorry, this was the kind of the AV thing that Katie was referring to. But if that's the worst mistake I make, it could be a lot worse. Okay, Prabhjot Singh is going to be first as a TED Talk. Prabhjot is director of the Arnold Institute for Global Health. He chairs the Health System Design and Global Health Department at Mount Sinai Health System. He co-founded the 1 Million Community Health Workers campaign and is a founding partner of City Health Works in Harlem, which is an amazing program. He's launched this incredible thing called Atlas, which is a new approach to linking satellite capacity with community health workers on the ground. And he's written a beautiful book called Living and Dying in the Neighborhood, about healthcare, which I encourage all of you to read. And like Raj, Prabhjot has also become a really dear friend and a great partner on so many of these things. So please welcome us. Come back up to the stage, and we're happy to welcome you. Thanks.
Thank you so much, Peggy. It's a real thrill to be able to speak with you about global health workforce, especially with the other people that I'll be speaking with, who are an inspiration for me. And even as I discuss something that is a bit more technology-oriented, it's fundamentally rooted in the practice of what it takes to deliver community health. Over the last about 15 years, I've both trained as a scientist in technology, but also in working with community health workers across sub-Saharan Africa and also in Harlem, where I've trained. And one thing that really just amazed me is that most people, when you're a community health worker, you're alone in rural areas. And you may have the contacts and you have the household interactions, but you don't know what the 100 other colleagues spread out over 100 square miles are doing. You're part of a team, but you don't know and can't hear from that team except for weeks to pass and understand what took place that you collectively achieved. When it comes to issues like pandemics or global health surveillance or security, you really need those teams to come together quickly, and they need to be able to act seamlessly over hundreds of square miles, potentially. So how do you solve that problem? And that's what we really focused on. And we've been inspired by the work that colleagues here have done during the Ebola crisis. But at the same time, in Harlem, when you have kids with asthma in houses, with people seeing them, so many different types of people, how do they know collectively what hundreds of people are seeing and experiencing in a neighborhood? How does that come together, and how do we act? So what we've done is launch a platform called Atlas. And it's built really with kind of modern technology and design methods, which means that it's not just technology, it's fundamentally built with designers, user researchers, people that really know how to build interfaces that motivate people to be part of a larger process. What amazed me is that when Zika first hit the United States in Florida, we were able to, in the US, quickly narrow down to this size of an area, blocks in Miami Beach. And that, over the course of the days, people were deployed against that, and that window got narrowed and opened and closed, and we realized, where do we have to focus our energy? If you have 1,000 people that can work on an issue, you really need to know what the zone is that you're going to be interacting. You need to know, what do you not know that's important, and then send more people out to deal with them. And then you need to be able to act when you're there. Now imagine that you're in parts of rural Liberia or Tanzania or Kenya, where I grew up, and the ratio of health workers to people is 1 to 28,000. For instance, South Africa, 1 to 16,000. In Manhattan, places like Miami Beach, 1 to 500. You have to be incredibly good about narrowing down your focus as quickly as possible. And during the Ebola crisis, what you generally see are maps like this, entire countries that are said to be unknown, big question mark zones. So how, when you have a fraction of the people, do you start to narrow down and figure out what is actually the work that you need to do? How do you start to narrow down this zone? This is fundamentally a story about how do teams work together across scales and time and come together. What amazes me is that little dot on your right, that little area in Miami. This is to scale in Guinea. And what we have learned is that, especially in the context of a pandemic, hours count. Weeks are too long. And so how are you going to quickly narrow down where do you need to act? Again, it comes down to how teams interact across space and time. What has become really important for the Atlas system is, what is the speed of response in a community? That's how we measure progress. What is the accuracy of how you're using your people to actually come and solve a problem? And once they get there, do they have the right information at their fingertips? What we know is that that form in the background is usually what people have to deal with. They're dealing with long spreadsheets. They have to make sense of it. And it takes weeks for people from the front lines to get to the decision making from ministries or organizations for it to be sent back. With the Atlas system, our goal is to go from 4 weeks to 4 minutes. With smartphones, which are deployed now in some of the most remote areas, we want the accuracy to go from a whole country down to 2 blocks. And that means that the team that's going to solve this problem are not physicians, they're not nurses alone, they're going to be community members, they're going to be health workers, they're going to be a whole group of new people that are needed across the world, but are actually the bulk of all the new health workforce in America as well. And finally, we need context. This is a room, I'm sure if you've been traveling to clinics abroad, this is in Kenya, you see that this is how records are stored. It tells you something about how useful they might be at the point of care. Now, in the US, we have records stored like this electronically. They're not that different. The question is, how can we get the right information for you at the right time? So I'd love to just show you what we've done. This is in a city 5 hours outside of Guatemala City, in Coban. And what we've done is we sent a team for 5 days to rapidly bring together all their information, understand what they don't have, and start to build it on a satellite layer that you see here that allows them to see all of their clinics, starts to understand what are the roads that they have there, what are the community-based assets that are available for them, and then start to formulate a plan. We work with people to say, well, what is it that you want to be able to solve for? And in this case, all this movement you have here are they want to know the cases, they want to know where their pregnant women are, they want to know where their kids under 5 are. They want to know what is that hotspot zone that they have to really zoom into and give their attention to. And so what we have is the ability to kind of immediately map out that kind of shaded area where people are already going into the communities and where they aren't. And ultimately, if you have an issue like nutrition, under nutrition, you don't want to just see the clinical information. You want to be able to see, as we have in these green areas, the satellite starts to map down where are the fields, where are the areas of grains being produced. If there's a heat wave, as climate information comes in, where are you going to have crop burnouts? And this is the equivalent to kind of in the US, a food desert. What are you going to do? And in this area 5 hours out of Guatemala, nutrition is not a clinical issue. It's an agricultural issue, it's a food issue, and you need a whole different type of team to come together to solve it. And so what we've done is created a system that looks like this if you're sitting at the high level at a district. But what you see if you're a frontline worker is a very different view. You just get just the contextually relevant information that helps you drive an action. It motivates you. It tells you what is your colleagues doing, what are your 100 other colleagues doing in that same place, and how can you act together. This is something that we're actually taking a new approach to prototyping it. We're prototyping this in Guatemala. We're prototyping this soon in Sierra Leone, but also in Harlem, New York. What we're starting to understand are the principles of how do you organize big teams over space and time. There's a lot of common elements to it. And you might say, my gosh, the US is so different, but one thing that we do need in the US right now is a dose of simplicity, pragmatism, and practical approaches that are really focused in the community setting. And we get that discipline by working with our colleagues abroad, and we begin to understand the larger team that's involved in community health. So very briefly, I just want to share with you that the team that's able to do this sort of thing are new people to global health. They're enriching the global health workforce by bringing in technologists that come in from climate science, from backgrounds of Google, even D.E. Shaw, that want to do mission-driven work. We have designers that are coming in from places like Dropbox, starting to help us understand what are the right types of interfaces, what motivates people along the way, and they're complementing a real grounded-based workforce of new health workers that are coming in, and we all need to learn together what does the future of how we organize ourselves to deliver care look like. And so, finally, all I'd say is we're at the start of a journey. And last year at Aspen, we launched this project. We received support from USAID's Next Pandemic Threat Fund. And over the next year, and recently we were awarded a Gates Grand Challenge. And it's the start of a journey for us to really explore and work with teams over large areas, give them the tools for people that we don't usually think about building technology for, those people on the front lines. And I think what it does is enables us to be part of a conversation that is grounded ultimately in community level, street level reality, and yet starts to bring to it the best that we can in terms of what other industries and technologies can offer. Thank you.
That was great, Prabhjot.
Thank you.
So I just wanted to, that was really pretty incredible, to just bring this down to reality. This looks kind of space age, right? I see Miami, and where is this being used now? I know that you are a startup. Where are we able to see this working?
Yeah, so what you actually saw was essentially a live video of our work in Guatemala. So it's deployed in Guatemala, and I think what we end up doing is we start scouting ahead to the new places that we are going to be working in, and we don't write a line of code until there's been heavy user research with the people that are going to be using it. We understand who the people and the teams are, what are the community issues, and then we start to build and bring it to the space age form.
Okay, so a lot of your life has been committed to really working in context. So perhaps you've, for example, been involved in this incredible work in Harlem, Community Health Works, along with your wife, City Health Works, and thinking about how the U.S. in low-income communities can learn from the global context. How does this, what looks sort of science fiction-y, gonna marry with your deep commitment to working in a respectful way in communities?
I love the question. One thing that we've learned is that across the world, I'll give you an example, in northwestern Kenya, they're tackling a challenge like hypertension, which is growing in low-income countries. They're taking community-based approaches, putting blood pressure cuffs in communities and organizing themselves in very different ways to solve that challenge. And what we're looking to do is put those things on platforms like Atlas, and we can learn how to do them here in New York City and in Harlem, and we're about to start doing that. So, in short, at the end of the day, it's just a platform, but it allows us to listen, allows us to learn, look for bright spots of how people are solving problems, and then very quickly start to say, hey, that's a great solution. Let's bring it home.
That's good. Prabhjot, you're amazing. I hope next year when you come back, people in the audience can say, let's pull up my city and look and see what's happening. And so that's my challenge to you.
We hope so as
We'll
well.
come back next year and
Thank
do
you,
it
Peggy.
interactive.
Thank you so much.
Prabhjot. You're really
thank you.
amazing. Great. Woo! I think he's going to be able to do that next year, guys. So just figure out what you want to know about what's happening in your cities. So next up is another really incredible innovator, Dr. Andrew MorrisSinger, who works in the U.S. He's a clinician, and he's another man obsessed with connecting people to meaningful, fulfilling work in the healthcare profession. But in this case, he's in a very different context. It's in the U.S. He founded Primary Care Progress, a grassroots movement to reform primary care delivery and clinical training. He started it a couple years ago, but it's already grown to work with thousands and thousands of healthcare professionals and volunteers and students and others all across the United States. And he's provided leadership training and leadership and advocacy training along the way. He's a former community organizer, so he crosses sort of the worlds of the health professions and community organizing. He's an assistant professor in the Department of Family Medicine at Oregon Health and Science University in Portland, Oregon. He's a lecturer in global health and social medicine at Harvard Medical School and an adjunct professor at the Department of Family and Preventative Medicine at the University of Utah. I think your family's here. I'm not sure how you're holding all those jobs with and also have your beautiful family with you, but we are glad you are, because this question of how to really rethink primary healthcare delivery is so perfect. So we're glad you're with us. Andrew, please join us and tell us a little bit about what you're doing. Great, thank you.
Thanks so much, Peggy. And it's humbling to be with such incredible people on the panel, so appreciate the opportunity. What is the value of primary care for you and those you care about? Sometimes the answer is crystal clear. That was the case with my mom. At the age of 65, at a time that she was perfectly healthy, my mom almost died, essentially because she lacked a primary care provider, someone focused on the full her. At the time, she had a pneumonia, but it was subtle enough that none of her specialists were able to pick it up. So it spread, untreated. My mom ended up spending 6 weeks on a mechanical ventilator in a drug-induced coma until they could finally get the infection under control. And that was when I learned the catastrophic health outcomes that can occur when people lack a primary care provider. A nurse practitioner, a physician assistant, a guide by your side. And over the last 10 years, I've seen the value, though, of primary care in people's lives. I've seen it in my own care. I've seen it in my colleagues' care. I'm talking not just about the big stuff, like avoiding a heart attack or stroke, managing chronic conditions like diabetes, or catching cancer early when it's treatable, but also some of the stuff that sometimes you might feel is smaller. Doesn't matter as much, but matters to you. Helping manage that chronic pain in your knee or your hip that isn't going away. Or helping you deal with this insomnia or anxiety or constipation that's been plaguing your life. And I know many of you have actually gotten to experience that value. But here's the deal. I also know that for many, many people, the value of primary care is less clear. Increasingly, primary care is not working for you. I'm talking about the really fast and short visits, right, where you get to spend 15 minutes max with your primary care provider. I'm talking about during those visits how they spend at least half their time staring at the computer screen, typing away. And by the way, what are they typing about? You just said 10 words, and they've been typing for 3 minutes. In terms of between visit communications, forget about it. You got a better chance getting access to your cable provider than you do your primary care provider.
Which is not saying much.
And by the way, who is that person again? Every time you need them, they're frequently not available. Primary care is not giving you the level of service that you get and expect from almost all services in your life. I'm talking about ready access. I'm talking about timeliness. I'm talking about consumer-centeredness, respect, efficiency, and above all, the best use of your time. Increasingly, primary care is not working for so many of you. But here's the deal. Increasingly, primary care is not working for us primary care clinicians either. A lot of us, we went into this field to take care of people like you, and help you not only with what is a matter with you, but focus on what matters to you. But increasingly, we're spending more and more of our time on the phone with insurers, getting hassled, right? Essentially, working as nothing more than glorified data entry clerks and scrambling to deal with all of these regulations, these requirements that are absolutely maddening. So whose fault is this, right? It's no one's fault. It's the system. Every system is perfectly designed to get the results it gets, and our system has neglected primary care for a long, long time. Just from a business perspective, right now, the reimbursement for primary care services is so low. It's so low that if myself and my colleagues, if we don't churn through these really short, fast visits, a high volume of those over the course of the day, we cannot stay in business. More and more practices are running on fumes, and more primary care clinicians are running on fumes as well. 1 in 2 primary care clinicians right now reports being burnt out with an intention to leave practice early. And this is on top of the fact that a third of the physician workforce is going to reach retirement age in the next 7 years, and they're not going to be replaced. The next generation of medical students, they're not going into primary care. Less than a quarter of graduating medical school students choose primary care, and that number should be half. That number should be more than half right now, because the American population, it's growing, and it's aging, and it's developing more chronic disease. More communities in America are facing effectively what you might consider a primary care famine. I got to visit one of those communities recently. It was rural Western Massachusetts. I was giving a talk at a local college about the importance of primary care. And I was invited to dinner with members of the community and members of the faculty. And there they described what it was like dealing with a primary care crisis in their community and the impact that it had had. And it was depressing. And after dinner, I was approached by one of the invitees, a local high school teacher. And he pulled me aside, and he quietly confided to me with this profound energy of shame that he had been a primary care doc in a nearby community years earlier. He'd taken care of thousands of patients. But he'd gotten so suffocated by the regulations, the documentation requirements, the hassles, the intrusion of the patient-clinician relationship, that he just said, enough is enough. I am done. He shut down his practice, he took a massive pay cut, and he became a high school teacher. He burnt out, and all of his patients, all 2,100 of them, they lost their primary care clinician, just like that. And I bet you if we went back to that community right now, we'd find a huge proportion of those patients still lacked a primary care clinician. We're seeing an exodus from primary care, and it's accelerating in this country. And oh my goodness, am I being a downer right now. Now, I realize we're in Aspen, and I think that this issue is going to affect you personally and people that you care about in the coming years because it is growing so significant. At some point, you might lose your primary care practitioner and have difficulty replacing them. Now, some of you are going to be able to get a concierge doc. But many of you, and most of your children and most of your elderly parents are not going to be able to afford that $25,000 annual retainer fee. And so you're going to face the world potentially without primary care. What is the impact of that? It depends. For your young and healthy kids that have just left college, they're probably not even going to notice for a while. For those of you who are relatively healthy, you might face a lot of inconvenience. You might face a lot of stress as you try and navigate this system. But for those of you who have significant health issues, for those of you who have elderly parents, the results of going around without a primary care practitioner these days can sometimes be catastrophic. Just ask my mom. So what's the plan? What are we going to do to deal with this? And with that, I'd like to ask Raj to come up and talk. No, I'm just kidding. But on a serious note, friends, as we consider the range of strong policy proposals to revitalize primary care in this country, and there are a lot out there, I want to offer the following. And this comes not just from being a primary care doc. This comes from, as Peggy was saying, being a former community organizer. We need patients and primary care clinicians to partner to save primary care. We need patients and primary care clinicians to come together to collaboratively not only design what primary care should look like, but to advocate for the remediation of the various obstacles that stand in the way. I'm talking about the crazy reimbursement rates that drive the short visit. I'm talking about those crazy insurance company policies and strategies where they're regularly dumping primary care providers from their network. I'm talking about the regulations, the protocols, and the rules that have your average primary care practitioner essentially handcuffed to the computer. Patients and clinicians need to come together to mobilize and leverage their collective power. Now, in order to do this, though, we're going to have to get real. We're going to have to get real with each other. Okay, we're going to have to start talking about the elephant in the room, our common pain in primary care, right? So just like those conversations that we all used to having with our significant others, we're like, I just want to talk about how this is not working for me, and I want to talk about it with you, sweetie. Okay? We need to have a similar conversation with our primary care providers, maybe just a toned-down version of it. So picture this. Next time you're in your primary care office and your primary care practitioner is finishing up the visit and she's walking over and she's got her hand on the door and you're basically done, picture yourself doing this. Wait, I want to ask you a question. How are you doing right now? I get the sense that this system is not working for you. It's definitely not working for me. And I would love to know if there's something we can do together to make it work for us. I know what you're thinking. I know what you're thinking. I know what many of you are thinking. Whoa, we're not in Kansas anymore, Toto. I realize I'm asking you to be vulnerable. I realize I'm asking you to do something that feels disruptive, to participate in the morphing of the patient-clinician relationship from a one-way street, a power differential-laden encounter, to more of a partnership, right? A partnership not only focused on you and your health and well-being, but also rebuilding that space, that relationship, so essential for it. I realize it feels like I'm asking you to start a revolution. I'm asking you to start a conversation. Now, how's your provider going to respond to it? Most likely, when you say it, they're going to respond with shock and silence. But that's okay. We can deal with that. This is different for them. They're used to helping you. They're not used to asking for help. But we got to start somewhere. We got to start this conversation somewhere. Because John, the family medicine doctor up in Oregon, whose practice was informed they were getting dumped from their insurance network, it was this exact conversation that he had with some of his patients that ultimately led a group of those patients to come together and advocate and pressure that insurer to back off. This conversation led to a collaboration that ended up saving their primary care. You see how this works? I'm talking about putting a stake in the sand. I'm talking about enough is enough. So let me end by saying that if and when you decide to have this conversation with your practitioner, know this. This simple set of questions and comments of how are you doing? Here's how I'm doing, and what can we do together to make this system work for us? That simple set of questions, you are going to be making a profound statement that cuts through all the burnout, all the hassles, all the check boxes. A statement that you care. You care not only about your well-being, you care about them. You care about their well-being. You care about the relationship. And you are ready and willing to be the ally and partner with them to push back and save primary care. So consider that the next time you're in the office. What would it look like to start a conversation, to cause a little bit of disruption, to lead to a new partnership that ultimately enables you to affect changes we could never affect on our own and save primary care? Thank you.
Andrew, you're so awesome. We're so glad. How are you feeling?
Good. Thirsty.
Changing the relationship. I'm sure people are going to have a lot of questions, and I have a doctor appointment next week. I wonder if you could come with me, because I know how he's going to react.
Yeah.
He's going to say what's wrong, and then we're both going to be stuck in this place together, you know. So I'm eager to hear, what's the next stage in the story.
Yeah. So I think the bottom line is that this is a journey that really needs to start. And we really have to be the generation that starts this journey. That we have been advocating in the healthcare space, in our silos, on our own for far too long. And ultimately, we've got the patients over here, we've got the primary care family physicians over here, the general internists over here. And what's ultimately ended up happening is that we're all engaged in this sort of us versus them world, right? The sort of my way or the highway. You either agree with me on everything and you're just like me, or, we can't work together. And when we do that, we relegate ourselves to the world of us versus them, where there's so few of us and there's so many of them. But if we're willing to start building partnerships, if we're willing for patients to start working with clinicians and family docs to start working with internal docs, then we're no longer in the world of us versus them, but now we're in the world of our friends, our future friends, and all that's left at that point is this tiny slice of people we actually have to destroy.
Andrew, let's give a round of applause for this amazing disruptor. Wow, I didn't realize you were going to have you're really awesome. Thank you. That was awesome. Great. This is good, guys. Let's get your questions ready because we're going to bring everybody back up. The next person is also a disruptor, huge disruptor, who we always like to say this, we've said this 3 times now, but we did meet in a bar. Dr. Raj Panjabi. And the drinks were so unimportant compared to the conversations we started to get into. Raj Panjabi founded an incredible organization called Last Mile Health. He's done a number of things. He escaped from his native Liberia at age 9. He went back to his native Liberia as a medical student and founded an organization to serve so many people that were not able to get any kind of health care in Liberia. He's having quite a year. It's a little surreal. We all need to bring him back down to reality. We can ask as hard questions as we want. He won the TED Prize this year for $1 million. He won the TED Prize, and he was named one of the 100 most, I keep forgetting the adjective, influential, funny people 100 in the world. And so we're going to try to keep him down to reality. He needs us to do that. We're his friends from Aspen. But Raj is really amazing, and he's going to talk a little bit about, he found himself in the middle of one of the greatest health crises that we've had in recent history, and that's the Ebola crisis in Liberia. And so Raj is going to share with us his story of health workforce in that context. Raj, please join us.
Kind of depends what time the drinks and what time of the day you have the drinks and the conversation, which one matters more. So amazing, Andrew. That is so inspiring. Thank you. As a primary care doctor that trained across the street from Andrew, I'm just in awe. So I want to talk about primary care in rural parts of Africa. I grew up. This is me in the 4th grade, the chubby little dude down there. I was a total math and science geek. This is from my 4th grade class in Monrovia, Liberia. My parents immigrated to West Africa in the 1970s, and I had the privilege of growing up there. I was living the kind of life that really any child would dream of. But we have this saying in West Africa, something my dad taught me, no condition is permanent. And when I was 9, civil war erupted in my country. And within months, the rebel armies had surrounded our hometown. I was able to escape with my family. We were the lucky ones. We ended up in America, and I had a community of supporters that surrounded our family, helped my dad start a clothing shop, and helped mentor me. I had the chance to go to medical school. It had been 15 years since I had escaped that airfield that we fled in Liberia, but the memory of that time had not escaped my mind. I had the chance to have my condition changed. I wanted to go back to Liberia when I was a medical student to see if I could serve the people we'd left behind. And when I got home in 2005, what I found was utter destruction. The war had left us with just 51 doctors to serve a country of 4 million people. To put that in perspective, it'd be like San Francisco having just 10 doctors. So you can imagine if you got sick in the city where those few doctors remain, you might stand a chance. But if you got sick in the remote, rural rainforest communities where I had been asked to serve, where you could be days from the nearest clinic, I was seeing my patients die from conditions no one should die from in the 21st century because they were getting to me when it was already too late. Imagine for a second you had a 2-year-old, and she woke up one morning with a fever. You'd panic because you realize that she could have malaria, and you know the only way to get her the treatment she needs would be to get to the riverbed, get in a canoe, get to the other side, and then walk through the forest for up to 2 days just to get a diagnosis from the clinic. You know, there are actually 1 billion people on this planet that have no physical access to care. And we've made some great, great innovations and technologies in modern medicine in the last couple of decades, but these have not reached the last mile. These communities have been thought of as too hard to reach and too difficult to serve. Illness is universal, access to care is not, and realizing this lit a fire in my soul. No one should die because they don't have access to a doctor. No one should die because they live too far from a clinic. You know, in this situation, that mantra, no condition is permanent, kept ringing in our head. And help in this case didn't come from where you might expect it. It didn't come from the outside, it came from within. It came from communities themselves. Way out in rural Liberia, this is a friend of mine, Musu. Musu is pretty gritty and persistent. Most girls in rural Liberia have not had a chance to finish primary school. Musu had been persistent, and at the age of 18 had finished high school. When she came back to her community, she saw children in her village dying from conditions like malaria and pneumonia, treatable conditions. And so she signed up to do what many of us would probably do, try to help. She wanted to help her neighbors, and so she decided to become a volunteer, a community health volunteer to serve her people. Now we got to thinking, there are informal volunteers like Musu across rural parts of our world. And we started asking, what if she could be part of our medical team? The work of doctors and nurses is concentrated in cities. That's where all the diagnosing and prescribing of medicines happens. Rural communities like hers have been left behind, but what if she could be part of the medical team? What if she could be the center of the medical team? What if volunteers don't need to be volunteers, but could actually have jobs? What if she could actually be a health worker with us, with doctors and nurses? So we started asking, what if technology could support her? What if we could train her? What if we could equip her with real medicines? What if we could give her the chance to have a real job? My wife and I were getting married around the year I was asking these questions in 2007. Our wedding was coming up, and we decided, I am a doctor, I'm not a business person, I'm not a nonprofit leader at the time. I didn't know how to raise money, so we asked our relatives coming to our wedding if they would give us donations in lieu of the wedding gift registry. My wife didn't really marry me because I'm that romantic, I promise. We ended up raising $6,000 from our wedding. We funded 30 community health workers and started a nonprofit organization called Last Mile Health. And our vision is to bring a health worker within reach of everyone, everywhere. And how do we do that? So we train, equip, and pay community health members like Musu to bring medical care to their neighbor's doorstep. So first, we trained Musu on the 30 life-saving skills that we know are proven, that can be done right in the community, like treating children for malaria. We equipped her with modern medical equipment like this $1 rapid test kit, and we enabled her with a smartphone to track and report on things like epidemics. A nurse coached her, and we recognized the dignity in her work. With the Liberian government, we provided a contract, negotiated a contract with her, and paid her, gave her the chance to have a job. She's amazing. She's done over 30 medical skills, from screening children for malnutrition to diagnosing with a smartphone the cause of a child's cough and shortness of breath. She and her colleagues have supported women with HIV to recovery, and supported those who've lost their limbs. Working as paraprofessionals, making community members part of the medical team can help ensure that some of us get schooled better, like myself in this picture, but that we can bring some of primary care, modern primary care, to places where otherwise primary care would never reach. A few years ago, I saw this power to believe that conditions that we've seen for centuries are not permanent. I saw the power of our innate desire to serve our neighbors really come out when in December 2013, across the border from us in a rainforest where the roads are sparse and the health workers are short, a little boy called Emil died from vomiting, fever, and diarrhea. A few weeks later, his sisters died. A few weeks later, his mother died, and this mysterious disease would spread from one village to another. And it wasn't until March 2014, nearly 4 months later, before the world recognized this as Ebola. By then, the virus had spread like wildfire across West Africa. Airlines started cutting their routes to that part of the world. At the height of the crisis, when we were told by the CDC there could be as many as 1.4 million people infected and that most of them would die, when we had nearly lost all hope, I remember standing in the forest with a group of health workers in a tent like this. We were training and equipping them, helping them wear the masks, the gloves, and the gowns they needed to keep themselves safe. And I saw the fear in their eyes. And I asked myself whether I was making the right call to keep those health workers in the field. When Ebola threatened to bring humanity to its knees, Liberia's community health workers didn't surrender to fear. They did what they'd always done. They answered the call to serve their neighbors. Community members across Liberia learned the signs and the symptoms of Ebola. They went door to door to find the sick, to track those that had been exposed to the disease, to break the chain of transmission. Some 10,000 community members across my country joined the medical team. They helped hunt down this virus and stop it in its tracks. I've seen the power of this idea to transform everyday citizens, volunteers, into professional community health workers. And I've seen it play out everywhere from the forest communities of West Africa to the fishing villages of rural Alaska. They're not doing neurosurgery. They're not a panacea. But they're making it possible for us to bring healthcare within reach of everyone, everywhere. So now what? Well, we know that the fight isn't over. 8.9 million people are dying across the world every year, mothers, children, and newborns, from preventable causes, and we know that that's happening primarily in these 73 countries. We also know that if an army of community health workers were trained to do just 30 life-saving practices, and they were expanded to reach those rural people, we could save 30 million lives by 2030. 30 practices could save 30 million lives by 2030. That's not just a blueprint. We're proving in this room it can be done. In Liberia, in Rwanda, in Kenya, in Sierra Leone, in Malawi. These are countries that want to hire musus for every child and family in the country and connect them to clinics. If we could help these countries scale, we could save millions of lives and at the same time create millions of jobs. We simply can't do that, though, without technology. Technology has been thought of with automation as stealing jobs, and that's true in some cases. This is a case where technology is actually creating jobs. Without technology, without this dollar rapid test, without this smartphone, it would have been impossible for us to employ and train musu. And now we need technology to help us train people faster and better than ever before. You know, as a doctor, I keep up to date and certified using my phone. I keep up to date with video lessons. But when Musu wants to learn, she's stuck learning from flip charts. Why shouldn't she have the same opportunity to learn as I do? if we want to change the way these health workers learn, if we want to bring healthcare to everyone everywhere, we have to change this old school top-down education model. And I've been really moved by what I've seen in the education sector. In the last decade, you've seen this revolution in digital education, the use of technology to democratize education. And I think it's time. I think it's time for a collision between the digital education revolution and the community health worker revolution. And that's why this year, with support of Aspen and TED, we launched the Community Health Academy, which is going to be a global platform that will train, connect, and empower community health workers around the world. The vision is to try to contribute to the training of the largest army of community health workers the world has ever known. And here's the idea. So imagine Musu is not stuck using flip charts to learn, but she's getting video lessons on how to give kids vaccines. Imagine Musu is not stuck looking at that child who's 2 years old with vomiting, fever, and diarrhea and guessing whether it's an outbreak, but she has a podcast to help her. She's connected to the rest of the world. She's connected to managers and policymakers. Imagine countries being able to see how good their community health workers are and equipping and training them faster than they ever could. Imagine those countries being able to accredit these workers so they are not stuck remaining an undervalued group, but become a recognized, empowered profession like nurses and doctors. Imagine if we could have a true revolution in healthcare. The goal is to prototype in Liberia and a few other countries and then take this global, including to rural North America. My dream is that one day this academy will contribute to the training of hundreds and thousands of community members to treat and care for hundreds of millions of their neighbors, from the forest communities of West Africa to the fishing villages of Alaska, from the hilltops of Appalachia to the mountaintops of Afghanistan. And if that vision is aligned with yours, we hope you'll join us by going to communityhealthacademy.org and let us know if you or someone you know or an organization you know wants to help us build this out over the next year. You know, there are already so many people in this room involved in this really audacious cause and effort, and I want to end with this reflection. My wife and I recently learned that she's pregnant. I have 2 boys, and I now have a daughter on the way. She's due in early October, and she can't wait till I get back home. I was recently caring for a pregnant woman in Liberia, who, like my wife, was in her 3rd pregnancy. But unlike my wife, she had never had any prenatal care with her first 2 babies. The reason is she lived in a village that had been settled 100 years ago, and for the past century, they had no access to care, no health workers. Until last year, when a nurse recruited community members to be community health workers and go door to door to find care. And so here I was caring for this woman in her home with an ultrasound. We were chatting it up. I was asking her about her first 2 kids. I put the ultrasound probe on her belly to listen to the baby's heartbeat. She turned to me, stopped mid-sentence, and said, "Doc, what's that sound?" It's the first time she'd ever heard her baby's heartbeat. And her eyes lit up in the same way my wife's eyes and my own eyes lit up when we heard our baby's heartbeat. You know, we have this saying in West Africa, no condition is permanent. And I know there's a lot of people in this room that believe that. For all of human history, illness has been universal, but access to care has not. And I think it's time for all of us to go as far as it takes to change this condition together. Thank you.
Everybody put your hands together again for Raj. That's really beautiful. Thank you. That was beautiful.
Thank you.
Moving story. Incredible, Raj.
Thank you.
How can we help you in this room? How can we help you? And also, the other thing I want to know is you've had the opportunity to give this presentation to so many people who don't really understand what a health worker is, and they don't really believe it, that people have never had prenatal care. What message you use to tell them that this is possible to do, And what message can you give all of us for how we can support you in this?
Well, thank you. On the second question, I think if you would share the stories of these community health workers. We're not the only group working with them, and there's some in America. Team up with Primary Care Progress right here. There are 48,000 community health workers according to the Bureau of Labor Statistics. Let's have hundreds of thousands more, rural areas, urban areas. So I think right here in the United States is one way to help, is to share the story of these community health workers and to help countries like Rwanda, Sierra Leone, the work that AMP is doing. If you can share these stories, that will have a dramatic impact alone. The second is to go to the academy and sign up. If you have ideas for how we can connect to your community and train workers in those areas or contribute to training, we'd like to hear that. You had asked also about how to communicate the cause of community health workers.
Yeah, when people, you're going on and they're like, I don't get it, it's too far away. Because you've been able to pitch this to people who probably are skeptical.
That's right. I think people can get skeptical because the idea of having a community member learn is, the best example I have, certainly some may have traveled to Alaska where they've done this work for 5 decades. But think about the person you call when you have a broken leg or you fall down or you have chest pain or you have shortness of breath. Call an ambulance, don't you?
Yeah.
Well, the people that show up are not doctors. They're paramedics. Paramedics started in the 70s. They were war veterans primarily coming back from the war who were community members and had some medical skill and were professionalized to become paraprofessionals. Now, we can't imagine a healthcare system without those providers. That's the power of this approach. Applying it to primary care is already being done now. If it could be done more in a more serious way, in addition to the hospitals and the clinics, that would be tremendous.
Great. Okay. Thank you.
Thank you.
Thank you, Raj.
Yeah.
Also, thanks for being, and congratulations on the new baby.
Thank you.
It's the first we heard.
you.
Thanks for being with us. Oh, you might need to come down this way. Let me invite up, my next 2 speakers, we're gonna turn to a really lovely conversation between 2 incredible women. Can I please invite Dr. Agnes Binagwaho and Ajahn Poo to the stage while we set up our chairs. Woo! You may not realize this, but these 2 women have been more instrumental in improving healthcare delivery than perhaps maybe any other people that I've met this year. They're pretty special. Dr. Agnes Binagwaho is the former Minister of Health of Rwanda. She personally is responsible for transforming a country that was devastated after the genocide into the place that it is the only country on this earth that met all of its targets in health for Millennium Development Goals, including massively reducing child mortality, reducing maternal mortality, and part of the trick was the approach she took to health workforce. She created an army of community health workers, which is also Raj's and Prabhjot and others' wishes. She's also done a few other things. She just founded a university. She's very busy. She likes to work very hard. The University of Global Health Equity. And we are really delighted that you've joined us this year. She's my new best friend. But she's also really powerful, and she does not pull her punches. Part of her success has been really pushing back about what her people in her country deserve and not taking second best for that. Ajahn Poo, I've known for quite some time. Ajahn, we always love having you here. She's director of the National Domestic Workers Alliance and co-director of the Caring Across Generations campaign. A couple of years ago, Ajahn had this brilliant idea. There's a huge problem we do not have enough caregivers to deal with the elderly in this country, and there are huge numbers of people that are in very low-skilled work that are taking on those jobs. And so I heard you give one of the first presentations at Rockwood, and she said, we really want to create a movement. It's around a new approach to caregiving. And like any good movement, she said, it's like when you first fall in love with someone, you need to have a theme song, you share podcast lists. And she really created a movement around health workforce, around something that most people would say, not really all that sexy, dealing with the people who are community health workers in some of the poorest countries in the US. So among her many accolades, she's the author of The Age of Dignity, Preparing for an Elder Boom in a Changing America. She's a 2014 MacArthur Fellow and one of Fortune.com's World's Greatest Leaders. That's beautiful. I didn't know that. She's a recipient of the Ms. Foundation Women of Vision Award and the Independent Sector American Express and Gen Leadership Award. She's also a dear friend. And so these are two incredible women. I feel like I could just sit on the side and listen to them, but we're going to have a little bit of a conversation for a couple of minutes, and then we're going to invite everyone back on stage. So please save your questions. Let me come join you over here. Let me start by asking both of you, those are some pretty powerful presentations. Any thoughts, any reactions to that?
So many. First of all, if you're as inspired as I am by those 3 presentations, can we just give them a shout out?
Yes.
Give them some love. Incredible. Incredible. 2 things that struck me that are incredibly significant, I think, for any effective solutions for the future. One, about the power of investing in everyday people as a part of the solution, as at the center of the solution, people who are on the front lines, who are in the community, who are directly affected, are protagonists, right? They're going to be part of the solution in fundamental ways that we have historically maybe undervalued and underestimated. So it's a huge leverage point to really tap into everyday people who are on the front lines. And the other piece that really struck me was about technology. And so often the conversation about technology has to do with the kind of threat of displacement of people, the role of people, or of kind of new efficiencies in a peopleless world, like a kind of tech to solve everything kind of approach. Whereas I think the approach to technology that our presenters presented was really about how do we leverage technology to enhance the human experience and to enhance humanity and human dignity. How do we have technology support the role of everyday people to be more powerful and empowered and a part of the solution? I think that a lot of people ask me about robot caregivers because I work with caregivers. Almost every talk, what do you think about robot caregivers? Good, bad? And the truth is, I think robotics, artificial intelligence, technology can play a huge role in supporting caregivers to provide better care. Right? It's not about displacing caregivers. I don't want a robot taking care of my grandmother, but I do want a robot who can support my grandmother's caregiver to be much more effective and make the whole situation one that's more humane and dignified. Right. And I think that's possible.
Great. So humanity and justice.
But I'm going to tell my view on those 3 amazing men.
Tell me, Agnes.
They were men and we are women.
Yes. But you're all
gender balance. You can create no system without data.
Without?
Data.
Data.
You need to know your setting, analyze it, and find a solution, capitalize on results to do better. And this is data. So, second, you can do nothing at maximum of your possibility if you don't partner with your clinician, your community health worker, your nurse, etc. In America, you are quite breakdown. It's not only
broken down.
Yeah. And we can see that in the lack of social capital that the health sector has. So much that we managed to do better with creating the social capital with the same pills. Without social capitals, your pills is less effective. Now, creating community health workers, you need it, guys. Yeah, you need it.
We need it.
Yeah. People believe that we do that because we lack health professionals. Okay, it helps. We start shifting. However, the social capital we can create by educating people inside the community to educate, to express what are the risks in case of, and to make each and every citizen part of any type of response. This is the community health workforce. So And all the three there, follow them and use them to improve your sector. Don't let him go back to Liberia without leaving the skills here.
Very good. You heard that message. Okay, I know both of your work. I know both of you. Many, many, many times people told you you were crazy. And Agnes, when you said, I am going to rebuild the health sector in this country, tell us, what were the numbers before? What are the numbers after? How did you do it?
How I did, so I have to tell the truth. First 5 days, I was about to run away. I believe that I will lose my soul, my mind, because people were dying. I was doing the best. The child was okay during the day. I come the day after the child was dead. And hopefully there was no plane. It was a place forgotten from the world in 1996. And I sat on my bed and I decided, okay, I'm going to stay, but I'm going to fight. And I'm going to organize, and I'm going to find the loopholes and fit them with solution as much as we go. Of course, they believe I was crazy, but I didn't care. And hopefully also, there were big supporters. And third, we didn't have any other solution. So it was about to do that or to take a plane and run away.
Do you mean you didn't have professional doctors and nurses, so
No,
you had to create the community healthcare system?
We were 4 pediatricians
4 pediatricians.
for the entire country. We had less doctors than in Liberia at that time. We had no trust in the health professional because some of them has contributed to the killing in hospitals. So we had to rebuild all that, the trust, the skill. Second, the country had no schools of nursing. The medical school was producing around 20 doctors a year, etc. So it was the desert, and we had to do with what we have. There were no drugs, there were no... So I even have to learn to be more clinician than where I was working, where I had ecography, another professional. I had to learn to rethink even my practice. So how I rebuild it, I was not alone, of course. It was a team and a nation work. We use the principle of human rights, meaning information, participation, so that the community are part of the solution, but also coordination, harmonization, integration, using each and every dollar that we can grab to build a system. No vertical programs. The community health workers, we harmonize, elected by the people, 3 per village, same education, same referral. And as time goes, when we add on knowledge, we add on system using data. Data for reference, data for control reference, etc. And we have now a new, those community health workers, 3 per village, are educated in 6 weeks on syndromic approach.
How many do you have altogether?
45,000.
45,000.
Yeah. And now we have a new type of community health professional, 4 months of education that will accompany the treatment of chronic disease, because this is not the same to treat TB, malaria, etc., than diabetes, etc. And accompany people to die with dignity at home so that they are not going and left in hospital to die with unknown people when we cannot do something. You need it, guy.
You need it.
You need it.
We need it. This is very interesting. So let me turn to Aijen then, who's listening carefully to you about your rights-based approach. Describe the situation when you first started. I know we both know Paraprofessional Healthcare Institute in the South Bronx. You're organizing domestic workers. Describe the communities you worked in and how you did it to create this care and what approaches you used.
So I've spent the last 20 years organizing the workforce that works in our homes, caring for our children, our aging loved ones, people with disabilities, our homes themselves, as domestic workers, as nannies, as elder care providers. And most of that work happens very much in the shadows. We often compare it to the Wild West because there's very little in the way of standards or guidelines. You never quite know what's going to happen. And there's also this very long history of exclusion from some of the most basic labor protections that many of us take for granted. And so in that context, we've been working to try to improve the quality of these jobs, elevate the quality of services and the dignity associated with this work. And about 10 years ago, we started to notice that more and more of the workers who were originally hired as house cleaners or as nannies were suddenly being called upon to care for the aging loved ones of their employers. And it really kind of opened our eyes to a huge need on the part of American families for elder care. And it really spoke to a lack of real supports for working families when it comes to their care needs. And so families were just kind of getting support wherever they could. And then you had this workforce that was incredibly vulnerable, and to the point where the annual median income for a home-based elder care provider is $13,000 per year. So we're talking about poverty wages for people who are working incredibly hard. And what we saw was an incredible opportunity to invest in this workforce as part of the solution, to really support working families across the country around their care needs, but particularly in light of the coming age wave. As more and more people age and want to live at home and in the community as they do so, how do we have a strong, sustainable workforce that can be a part of the solution, ensuring the kind of quality of life that our loved ones deserve, the independence, the ability to live at home, and then also really being a part of a team or a squad that can enable healthcare efficiency.
Yeah, it's really powerful what you both have done, and I want to make sure we have time for questions, and so I want to go ahead and invite the others to come back on the stage and bring up the other chairs. But Ijen, how others have tried to do what you did, and I'm very aware of your singular voice as a part of being able to move this forward, and similarly with you, Agnes, other people have tried to do what you did. And so is there anything you can share with us in how you were able to have these accomplishments in something that is really difficult? So what do you think is the secret of how you were able, and also similar to you? What do you think? I mean,
well, like Andrew, I'm an organizer, and organizers never do anything alone. The whole theory of change is that it happens when people come together, and our whole approach has been a movement-based approach, that it takes a whole movement and ecosystem of organizations and leaders like Sarita Gupta, like David Rolfe, who's a leader who's built the single most impressive home care training institute in the entire country, training 40,000 home care workers per year in the state of Washington. It takes a movement, and what we've been able to do is bring the best ideas together and move them in the same direction.
Yeah. What's your secret, Agnes?
Participation, and also put science behind all those little acts that we do. You don't need to be a teacher in a university, but you have to have the rigor of it when you talk about nationwide. And that's why we have built an university to train the next leaders on those principles, because what they do, there are principles behind. And we need to transfer those principles for the next people who are in our situation to be equipped with the skills to start and not do the mistakes we have done, or not be afraid like I was, or not be doubting, because we build on what has already been done in a part of the world. And this is really skills that we can teach.
Beautiful, beautiful. Great. So let's open it up to the audience. We'd love to hear from you. There's a lot of questions. We'll try to take a couple at a time. I think we have a microphone. This gentleman right here, and then this gentleman. If you don't mind, I think we'll take 2 questions at a time and since it's such a rich conversation. Please, sir.
Hi, Cliff Devaney. I'm obstetrician gynecologist now, running a small health system in Ohio. We've seen empowerment, we've seen the use of human capital in a really positive way. For you, why do you think American physicians have become victims and become the ones we have to ask about why they're burned out? Why are they the ones that are in trouble? Yet people here are solving problems, they're making the world better, and what we're hearing is the most highly trained workforce, the most highly compensated workforce are victims.
Good question.
That's a great question.
Before you answer, can I just take one more question?
Please, go ahead.
Please, this gentleman right here, patiently with the black T-shirt, holding his hand up. Please, sir.
And it's quite a good pairing of the questions. My question actually is about the entrenched interests that are fighting you. You're disrupting a lot of things in a very creative way. Are there a lot of gatekeepers, government regulations, and all that kind of thing that are actually stopping you from creating these new kinds of workforces, the entrenched interests?
Good question. Great question. Andrew.
Yeah, so what I would say is I think that a theme running through this fantastic panel is that we are sitting on top of untapped healing capacity in our practices, in our communities, in our families. And what we're trying to do is find ways to tap it and unleash it. And I think that a lot of where the sort of victim mentality comes from and the angst and the anger, especially amongst a lot of health professionals in America, particularly physicians, is that they feel that they're not being harnessed. And all of their values and all of their training and all their commitment is being quashed by a whole variety of factors. And so I think the question really is, what can we do to unleash people? I think that's really the question that we have to figure out. And I think there are policy questions there. I think that there are regulatory. There's obviously a ton of reimbursement issues, but it's also sociocultural strategy that we have to develop to do this.
And recognition. You know, for me, my community health workers are my heroes. And when I face them, I tell them. And I show them why. They care about 80% of the burden of household. Without them, we will be nowhere. And also the fact that stop to be pretentious and believe that you are a doctor and you have everything and all the solutions. And that they cannot do the injection properly, they cannot they cannot reflect, they have a brain, just put the right thing in that brain.
Beautiful.
And
Let's
I can
take the
take
next
the question.
Please.
Well, you know, it's interesting. I think things are already disrupted, right? I mean, it isn't just in healthcare where we have issues of access and quality and cost, but just societally, right? I mean, when the return on capital outpaces the return on labor, right? When we know from books like Capital in the 21st Century, that's when capitalism and democracy and the rest of it just doesn't work. That's when you get things like Great Depression, when the inequality increases. What is going to create jobs for the future? The service industry has done that. Service sector has done that here. It's taken poor countries previously in Europe. The big driver of their economic growth has been employing labor, caregivers. Why shouldn't it be that way in Africa? I mean, the number one reason, other than the Minister of Health getting excited about this in Liberia, is that the president of Liberia is excited. Why? Because she's worried about the next civil war. And she knows that half of these workers are actually young, unemployed, previously young and unemployed men who are being put to work. And there is a link between a gap in someone's aspiration and the opportunity that they have. And when you don't resolve that gap, you get extremism and you get bad things to happen. So I think that's also an important perspective.
Absolutely. And the other thing, provide education, health, and love, the war will go away.
Education,
Also,
health, and love.
You need to train the community health workers up to the teacher in the top university in advocacy. So they can express the needs and also not burn on in their corner and be victim. No, they're active agent, and you need to transfer that skill to education. Third, multi-sectoral approach. I'm not a lawyer, a guy, but I need the law to work for me. So I need lawyer in my team. Multi-sectoral approach and more than lawyers. And also, we need to revisit the education sector. You are killing your doctors when you start to train them with loans that they will hardly have to pay. And to pay those loans, they have to be bad doctors. Because they see the money, they stop to see the patient. If not, they will not have a house. So we have to revisit everything. I start by education, she start by house, he start by thing. We are all together in the same fight.
Beautiful. Let's take some more questions. Beautifully said. Please, sir, there's one right up here, and then others.
Should primary care
Please, here's a microphone for you.
sorry. Should primary care doctors in the United States organize themselves and form a union?
Oh, interesting. Let's have a couple answers. And then is there one more question?
Yes.
The answer is yes already. Okay, let's start answering. Go, Aijen.
No, I mean, I
Should they
just
organize
think
themselves?
this is the thing, is that when we come together and we have a voice collectively and a plan and a strategy, and that's when things really change. That's how the best forms of disruption and progress happen. So I definitely, if doctors feel like they don't have a voice, coming together helps you have one.
Prabhjot.
I will just mention, I think one of the gentlemen also before asked about the policy and the regulation, et cetera. One thing that I learned earlier this morning at another Aspen event was just the term defensive posture, and that we just immediately move into a defensive posture. We can't do anything. We've got a cataclysm in U.S. healthcare. We can't do anything. But I moved from doing work in global settings to working in New York City, because when I read the rules, we can do a lot. In fact, there are breakthroughs in how we design services that you just need to have some of the leadership that I have seen over the last 10 years in Rwanda, and I'm starting to see in systems in the United States, even under our CEO, that say bring the breakthrough service designs and show us how do you do it. And I think part of that may be how do we organize? How do we say that if we've decided this is a good thing to do, how are we going to organize to do it? And I think it starts to address questions about going from a victim mentality as well to saying, okay, let's start to figure out how do you organize your power and start pushing forward.
So organize them. First article in their status, we are there to serve.
We are there to
And after that, let them fight for themselves. Second, when our community health workers, I have organized them for themselves to assure that nobody go and abuse them. And also that the problem can come from top to down and be considered by those who decide.
So I'd love to throw
Andrew.
one sort of take in here that I actually think we have to be, as health professionals, more sophisticated about how we organize and team. So I actually wouldn't recommend that we form a primary care doctors union. Because think about it from the perspective of stakeholders. They're just going to see that as another interest group. Let me give you a perfect example of being more strategic. Right now there's a campaign amongst primary care physicians in this country called Joy in Practice. Right? Joy in Practice. This is about creating joy in practice for physicians. How do you think that sounds to patients? Patients, they don't care about joy in practice. They're having all these other problems. They can't even get access. So we need to think about what is the brand, what is the issue that patients can get behind, that primary care physicians can get behind, that nurse practitioners, that community health workers can get behind. And that's what we need to organize, because that's when we actually have power. This isn't about us, feeling better. This is about us getting bigger. And I think we have to be more sophisticated when we decide to team and build coalitions and movements.
But the structural situation you're dealing with is your individual doctors or small groups are dealing with extremely wealthy, extremely powerful insurance companies to dictate the rates. I mean, we all know that the reimbursement rates for neurosurgery or orthopedics are, in some cases, a full order of magnitude above the reimbursement rates for the guy doing primary care. And that's a structural issue, and the only way for people to speak truth to power is to organize and speak, and to speak with a single voice.
So the women on this side are saying, organize. I'm hearing the voices. I don't know what the other side is saying over there.
But organize to serve. And if you put that in your legal framework, the patient will love you. Will love you because you are there at service and you organize yourself for better service.
Let's take some more questions. Right there, the woman in the beautiful hat.
What a remarkable panel. First of all, I think we're all just really stunned at how much we've learned in the last hour. So thank you. I have a question for Patrick. I love the idea of inviting patients to actually ask their doctors what's bothering them. I think many of us who have been patients a very long time have been told reimbursement, you can't change that. You know, X, Y, Z, you can't change that. Like, where are the biggest opportunities going to be as we start this journey? And others who have ideas on this as well, I'd also love to hear, you know, from a community health worker perspective and so forth. But thank you.
Good, thank you. So forgive me because I didn't quite get the question. Say it again. Where are the opportunities?
So I'm psyched to work with my primary care doctor, but he's just going to tell me that he has to like see 40 people a day, and that I will never be able to help change reimbursement. So that's just an example. You know, like maybe it's changing the healthcare teams of the future. I don't know, but like where are the biggest
real
opportunities going to be?
Okay, great. Anybody want to jump in on that one?
I'll throw out a few quick ideas. One of the biggest issues right now regarding reimbursement, the driver of that is an organization called the RUC, the Relative Value Update Committee. It is supported by the American Medical Association. It is the group that behind the scenes with no accountability determines physician payment. And it is a group that has overwhelming majority of specialists. There are very few primary care clinicians. There are no patients. That group makes recommendations to Congress. Congress takes 98% of them, and that's a fact. So that group actually is very poorly known to most Americans, and I think that is a first place that we have to start. But I'll also be curious what some of my colleagues think.
wants to speak, and then Dr. Agnes, please.
Well, I was just going to say that some of the most powerful advocacy that I've seen has been where disparate groups who've been siloed and often pitted against each other actually break through and organize from the place where their interests come together. And the whole Caring Across Generations movement is really about bringing families who need care and are struggling to afford it, and family caregivers in particular, together with a workforce that's really struggling to survive doing this work on such low wages, together with the consumers, the people with disabilities, and the older adults who want to live independently and have limited choices, actually bringing everyone together under one kind of movement to say we need a reinvention of how we support and care for American families in light of all the demographic shifts. And that is when you start to see enough power and enough different voices to catalyze a real culture shift that can lead to more transformative change.
Beautiful. Dr. Agnes, I'm going to give you the last word.
So I agree, but also back all those things with fact, data, finance, economy. Show how many the nation can save by cherish those practitioners. Also, the system, I'm talking of your system, I would love to have. Can you imagine? $11,000 per capita spent in health. You give me that and I cover all the planet with good primary care. Now, so go to your Congress people with fact, data, and how you need to protect that.
Beautiful. So we're going to have to close. I think you all will join me in saying these are some really, really great leaders, and we are so delighted to be here with you and to have learned from you. Thank you all.